Okay, good afternoon, everyone, and welcome to today's Grand Rounds. It's my pleasure to introduce Dr. Melissa Forton, a distinguished expert in infectious diseases. For today's Grand Rounds, Dr. Forton will be presenting on foodborne illnesses. Her insight and expertise are invaluable as we strive to improve patient care and public health. Please join me in welcoming Dr. Forton.
Thanks so much, Chelsea. Foodborne illnesses are my least favorite illness to experience, and they tend to happen more frequently in the summer and the warmer months. So this is a good time to kind of get do a quick review. Now these are called lots of different things. I typically refer to them as acute gastroenteritis, but you'll hear people say that they have food poisoning or the stomach flu or a stomach bug or lots of colorful terms. But if someone comes to you and says they have these, this is what they're suffering from, you know exactly what kind of symptoms they have. And having, kind of this acute gastroenteritis or these foodborne illnesses or animal transmitted illnesses are really common. And it's really tough to estimate how many people suffer from this per year. Because most of the time, even though the symptoms are generally really unpleasant, they're usually really short-lived. So most people don't visit a healthcare provider, or if they do, they don't get tested for, you don't know exactly what the pathogen was that caused the illness. But there still are a lot of people that get sick, that do go to the hospital or require hospitalization. And again, the bacterial causes of these illnesses tend to peak in the warmer months. And we see more of the viral outbreaks in the winter, although they can happen, any time of the year. The transmission is usually some sort of a, fecal oral route. We aren't walking around with poop on our hands, but we can have small particles when you're touching surfaces or interacting with animals. And if you touch your face or you eat without washing your hands, you just have that risk. Some of these, like norovirus, are typically transmitted person to person. You can get this with contaminated food or water, and then aerosol transmission, which is really unpleasant to think about. But these pictures show a toilet that's been flushed and the spray that comes from it at about 2, 4, and 6 seconds. So you could imagine, we've heard this before, that sometimes people say you should close the toilet lid before you flush because there is that potential for these particles to kind of float up in the air. But you can also imagine if someone is having forceful vomiting or forceful diarrhea and you're helping care for them, it's a loved one or a child, you can get these particles on you, or you can inhale them, or they can be on the countertop in the bathroom. So it's just really, really easy to spread, unfortunately. Most of the time, we're going to get these from eating meat that hasn't been cooked appropriately, unpasteurized dairy products, contaminated water, leafy greens or other vegetables that haven't been washed completely, or again, direct contact with animals. And as with many things, the groups that are at risk of having severe symptoms or having any kind of invasive infection are young kids, older adults, people that are immunocompromised, and in some cases, pregnant women as well. Now, this just shows some different types of pathogens. I'm only going to talk about a handful today, but there's some different pathogens. And you can see that the onset of symptoms varies, sometimes within 30 minutes, sometimes you may not get symptoms for several days. The duration, luckily for most of these, is going to be about a day. But some, of course, can last longer. And they can have a variety of symptoms, but the one symptom they all have in common is that they all cause diarrhea. A lot of them can also cause vomiting, belly pain. Not all of them cause fever, but the one thing they all have in common is the diarrhea. So when we see these patients, it's important that we get a thorough history. So we want to, ask lots of questions about if they're vomiting, what does it look like? If they're having diarrhea, how often? What's the volume like? What does the poop look like? Have they traveled? What about their diet? Have they eaten at restaurants? Have they been swimming lately? Or they could have, gotten water in their mouth or swallowed some water. And then any exposure. Have they been around anybody that's had similar symptoms? And generally, when we see these people, almost always we're going to get a metabolic panel to check electrolytes and kidney function. And then depending on how they look, their symptoms and things like that, we may also get additional lab work, and we may get stool testing. The treatment for all of these is really largely very supportive. We want to encourage rehydration. Folks, we always want to try oral rehydration if possible. Most of the time, if an adult seeks treatment, they've already tried, to drink at home and then they're not able. With kids, I'll always try if they don't look too dehydrated. But a lot of times people are going to need at least a little bit of IV fluids and then correction of any electrolyte derangements. Zofran can be given. It does in kids decrease vomiting, and it will decrease the need for them to be hospitalized. Oftentimes we can give Zofran and they're able to tolerate fluids and then are able to go home from the ER. Loperamide is an anti-diarrheal medication. The recommendations was something we don't give to kids. In adults, especially if people are traveling, it sometimes can be recommended to take loperamide. There's no strong evidence either way to support the use of using probiotics. There have been some studies that show using probiotics can decrease the length of the diarrheal portion of the illness. And there's been some that show that it's not super helpful. But the problem really is that because there are so many different pathogens that cause these GI illnesses and diarrhea, and we often don't know what that pathogen is, and the many different types of probiotic formulations, there just hasn't been a great evidence either way. The only time that it's really not recommended to use probiotics are for patients that are seriously ill or have some immunocompromised state, because there is a slight risk of getting an invasive infection. Bismuth subsalicylates, which are kaopectate and pepto, can be used to decrease diarrhea if you're traveling. This is something we typically don't use in kids either, and I don't think pregnant women should take it as well either. And then in general, there's no routine antibiotic treatment. For travel medicine, sometimes you can get a prescription to take with you on travel, depending on where you're going, and you can take that antibiotic if you develop these symptoms. Some docs are getting away from that, again, because we don't know what the pathogen is, and then sometimes we're giving antibiotics that aren't needed, and then we're driving resistance. And then stool tests. So when I worked as a hospitalist, we did not routinely do any testing on stools for most kids. There was no routine testing, but it can be done. The stool culture will look for E. coli 0157, Salmonella, Shigella, Campylobacter, and we'll also, we order stool culture, they'll test for Shiga toxin 1 and 2, and all of those are reportable. For norovirus, you can do a PCR. There are some other tests that can be done on stool, but I'm not talking about pathogens or anything. I'm sorry, I'm not talking about parasites today. There's also a stool panel. This is newer. It's not available everywhere. And in this case, it's similar to a respiratory swab where you get the swab and it tests for lots and lots of different things. So in the facilities that have this, you can send a small stool sample down, and it can be tested for lots and lots of different things that would replace the stool culture and the PCR and all these other tests. I don't believe that Norton has this yet. Probably will get it. One of the problems with it, of course, is that it's going to be expensive, and it doesn't give us a lot of useful information. As I said, most of the pathogens, it doesn't change treatment. It doesn't change the way we treat the patient. So it's going to be expensive. It doesn't change treatment. So that's, and then we don't want to overtest, right? But some of the benefits, of course, is that we can help identify pathogens. So again, while we don't treat many of these differently, it can help us identify a pathogen. It can help us identify outbreaks. And it's something, if from a public health perspective, it would be great to have some tests to identify these pathogens as often as possible. Now, there are some red flag symptoms in both adults and kids that, you're going to get more testing no matter what. So these are, in kids, this is going to be altered mentation if they have bloody or bilious emesis. any blood or mucus in the stool. If the little kids are just inconsolable, they appear toxic, fevers of 104 or higher, any kid that's under 6 months of age, and any kid that's immunocompromised. And those red flags are similar for the adult world. Any blood or mucus in the stool, if they have severe belly pain, or they've had diarrhea that's lasted more than a week, or they're having emesis, but no other symptoms, they're just vomiting without other symptoms. And then, of course, if they are having altered mentation or they're immunocompromised, these folks are going to get just a more thorough workup. The symptom that we end up treating most often and leads to the most hospitalization is dehydration. And so I'm not going to get into like the different classes of dehydration, but just in general, the symptoms would be decreased urine output, which can sometimes be really difficult to determine if you're having large volume diarrheas or kids that are wearing diapers. Still, it's hard to determine how much is stool and how much is urine. Dark urine, we've all been dehydrated. We've probably all had one of these GI illnesses at least once. So, the dry mouth, feeling really lightheaded or dizzy or weak. Little kids will cry, but they won't produce tears. And then, as this dehydration worsens, you can have a high heart rate, a lower blood pressure, delayed cap refill, and decreased skin turgor. And one of the things I wanted to mention is an acute kidney injury. So we have these different scoring tools that can stage an injury to the kidney based on, usually they're looking at urine output and serum creatinine. I think if they don't have them now, they'll probably start having some of these tools looking also at urine biomarkers like NGAL. But they'll have these stages 1 through 3, 3 of course being the worst kidney injury. And these can be pre-renal, renal, or post-renal. In the cases where people are dehydrated, it's going to be a pre-renal cause. And that is due to the hypovolemia and this decreased perfusion to the kidneys. So we want to identify dehydration and treat that aggressively so that we can prevent any kidney injury, because we know that any episodes of kidney injury can have long-term effects on kids and on adults. In kids, having an AKI is associated with an increased risk of chronic kidney disease, high blood pressure, and then increased mortality. One study looked at just kids that were admitted to a PICU for any reason, not related specifically to gastroenteritis, but for any reason, and found that kids who had an AKI had a 77% increased chance of passing away within a month. In adults, adults often have comorbidities that make the development of an AKI more likely. And if they have a kidney injury, it's associated with recurrent kidney injuries, the development of or worsening of chronic kidney disease, recurrent hospital admissions, increased mortality, and an increased risk of cardiovascular events. So again, we want to identify dehydration and treat it really aggressively so that we can prevent some of these long-term problems. And now I'm going to talk just about a couple of the pathogens. So Shigatoxin producing E. coli or STAC is one it's not one that we see a ton, but it is one that has the potential to cause some significant complications. And the 0157 strain is the one that we see most commonly in the US, although I think there are about 5 other strains that cause the same symptoms. So while E. coli is something that lives typically in our intestines and is a very helpful thing, there are these strains that are pathogenic and they produce these toxins, Shigatoxin 1 and 2. And these toxins are released when the E. coli die or are stressed. So when you get this, it attaches to the wall of the intestine and then it releases that toxin. And the toxin will cause the cells there on the surface of the intestine to die. The mucosa will just slough off, and that'll cause diarrhea, and eventually that diarrhea usually will become bloody. And once you damage that intestinal wall, that toxin can then translocate into the bloodstream, where it causes an inflammatory cascade that leads to red blood cell destruction and microclots, very tiny clots. And because the kidneys are so vascular, they're particularly susceptible to these clots, but it can affect the brain and many organs. This shows this outbreaks and the strains of E. coli between 2010 and 2017 in the US. And you can see that, even though I know better, I always still think of this as an outbreak associated with eating meat. But you can see that most of the infections were actually caused by vegetables. So most of the time, vegetables, then beef, dairy, fruits, game, and then so on. And then the colors represent the strain of E. coli. And again, that blue color is 0157. As I said, that's the one we see most often in this country. So we have about 95,000 cases per year, most of them in kids, mostly under the age of 5. I think the average age is about 2. And the problem with STEC is that about 15 to 20% of the kids will develop something called hemolytic uremic syndrome, which I'll talk about more in a second, but it is a real problem with the kidneys not being able to function appropriately. And this is an outbreak, this is a pathogen we see more often in the summer and fall. When we see these kids or these adults, they typically come in with watery or bloody diarrhea. They have belly pain, tenesmus, which is a really strong urge to defecate. So they may just constantly feel like they need to poop, even if there's nothing there to poop out. They typically don't have fever, but they may have a low grade fever. And sometimes they have nausea, vomiting, not always. And this shows a typical timeline. So most of the time, this is going to be ingested, and the symptoms will start about 3 days later. Around day 2 to 3, diarrhea will usually become bloody. And that's a lot of times when people will seek medical care because, having any blood in your stool is a concerning thing to see. So they'll seek care at that point. For most people, by about day 7, their symptoms are improving, and 85% just get better. They just get better and they don't need any further care. But about 15% develop that hemolytic uremic syndrome. And we don't know why those 15% do. We don't know why some do and some don't. But we have 15% who do develop HUS. Now, when we see these kids and they come in with this bloody diarrhea, we want to get a stool culture right away. And these kids will be checking their white blood count, their platelet count, and for any evidence of the destruction of red blood cells. Again, checking electrolytes and renal function. And we're going to do really aggressive high IV hydration. Aggressive hydration actually can decrease the risk of developing HUS. So we want to make sure that we're really tanking them up. Now, if they do develop HUS, again, about 60% will require dialysis, 80% will require a blood transfusion, 20% will have neurological complications. And even at a 5-year follow-up, 4% still have some CNS sequela, which could be seizures, coma, stroke, paresthesia, or severely delayed motor development. And about 30% have some sort of renal sequela. So they may have kidney disease, which in this study that I have on here was for kids with a GFR less than 80. They could have high blood pressure or protein in their urine. So again, we want to identify it, avoid it if we can. It's really unfortunate. If our kids are hospitalized and they do develop this, we want nephrology involved right away. Daily weights, we're going to, at this point, limit fluid. So we've been aggressively treating with fluid, but now because the kidney is not able to filter and behave as normal, we have to limit fluids and limit some of those electrolytes. Again, giving blood, and they have to be monitored really closely in case they need dialysis. Now, one of the good things is that typically when they need dialysis, this is a temporary thing. They need dialysis maybe for a week as they recover. Now, my least favorite is the norovirus, or it was called Norwalk, and then the winter vomiting disease, which tells you everything you need to know. It is the leading cause of foodborne illness in the United States. And symptoms are nausea, vomiting, belly pain, and diarrhea. And it can lead to dehydration, and it's responsible for the majority of hospitalizations. And everyone is at risk. It doesn't matter who you are, it spreads super easily. It is transmitted. This is the one that's most often transmitted person to person. Of course, contaminated food or drinks, touching those contaminated surfaces and any spray. I did see a study that's not in my slides. A patient or I say patient, but it was a person that vomited in a dining room. The staff cleaned that up very quickly, but all the people at the tables nearby got norovirus. It spreads so easily. And unfortunately, when you suffer from norovirus, again, usually it's short-lived. You feel better, but you are still spreading it for 2 or more weeks after you recover. And in these cases, alcohol-based hand rub isn't effective, so you have to use soap and water, and you have to do cleaning with the bleach-based products that can survive for a very long time in the environment. It can survive for weeks on surfaces, and if it's in water, it can survive for months. Again, this is the one we see these outbreaks of, like in cruise ships, where half the people on the cruise get sick. This is usually due to norovirus. We can do a PCR test on stool to diagnose this, but it's not like routinely done. Salmonella, non-typhoid salmonella, causes lots of infection, over 1 million infections per year. And it's non-pathogenic in many animals. So like STEC, it can live in the intestines of cows, pigs, chickens, it's in amphibians and reptiles, so people that have lizards and things like that, you have to be careful. It doesn't cause them any illness, but just interacting with these animals, working with them, touching their environment, can transmit those pathogens onto our hands. And if we're not careful, then it's in our mouth and we're sick. These typically is going to be diarrhea, fever, belly pain, and symptoms. You can see this wide range. You can get sick within 6 hours or several days after, and it can last up to a week. Again, food, water, and animals. Again, it's often not tested, but a stool culture would be the test to test for this. The treatment, again, is supportive. Although it's a bacterial infection, typically we don't use antibiotics. We can, but it doesn't shorten the length of illness. However, if you have someone that's at high risk of complications or an invasive disease, they go ahead and give antibiotics, but again, not typically given. Clostridium perfringens also affects a lot of people in the US. There are some different types. Some are associated with gas gangrene and then some with GI illnesses. So these, again, these are able to reproduce very, very rapidly. They produce toxins that cause cell death in the intestines. Usually the people will have diarrhea and very, very painful belly pain. They usually don't have vomiting. Symptoms usually begin really suddenly, as soon as 6 hours after ingesting these, and they only last about a day, luckily. These are often transmitted via food when large amounts of food is cooked in advance, but it's not kept at the appropriate temperature. So think of like buffets or, church suppers, like that kind of thing, where you make a lot of food. And you cook, you may cook it to the appropriate temperature, but it may be out long enough that it gets below 140 degrees, and then these guys grow. I think they can double every 8 minutes. So they can multiply rapidly. We usually don't routinely test for C. perfringens, although when there's an outbreak suspected, the public health labs might test. Campylobacter is one of the most frequent causes of bacterial illness in the US, and this can also cause bloody diarrhea, belly pain, and fever. Symptoms begin a few days after infection and can last up to a week. These again live in animals and spread to people via food and water and animal contact. Again, those we don't typically give antibiotics, but we can, especially to those that are at high risk of severe infection. And then I will mention listeria, I think, if I was stuck for a second. So this is one we don't see a whole lot of, but there is a higher risk of morbidity and mortality. It causes about 1,600 infections and 260 deaths per year. And the group particularly at risk are pregnant women and newborns. Early in the pregnancy, like in the first trimester, women may have fetal loss. About 20% of the time will have fetal loss. The symptoms of people get listeria generally are very mild, so you may not even realize you have it. Even a pregnant woman that is going to unfortunately have a miscarriage may not even have significant symptoms. Later in the pregnancy, it can cause more significant symptoms like a fever and headache, almost feel like you have the flu, but it can also cause premature labor. newborns that have listeria will often have meningitis. So it's just something that we want to avoid if possible. And it's spread via unpasteurized soft cheeses, cold deli meat, pre-made deli salads, and unpasteurized dairy products. And listeria, unfortunately, can grow even when we're caring for our food appropriately. When we have it in the fridge, we're not taking it out and letting it get warm. It can grow even while it's being refrigerated. And then these are just some handouts from, I think this is foodsafety.gov and the CDC, just things that we can give pregnant women that helps identify which foods are risky, why they're risky, and what some good alternatives are. So now we've talked about some of these. So how do we avoid them? Well, we don't want to have anything unpasteurized. We want to make sure if we're having fruits and veggies that we clean them with running water, rinse them off, scrub them if needed, and we don't want to peel or cut them until we've washed them. We want to make sure we're cooking to the appropriate internal temperature. We don't want to thaw food on the counter. Ideally, we can put frozen food in the fridge and let it thaw over a few days, but we don't want to leave it on the counter. Leftovers in the fridge should be eaten within 3 to 4 days. We want to make sure we are having really good hand hygiene after we're in contact with animals. We want to isolate people that have a diarrheal illness. At home, you want them, if you have more than one bathroom, have one dedicated bathroom for them to use while they're sick that can be cleaned thoroughly with the bleach product before anyone else in the family goes in. We don't want these folks at school or at work. We don't want them preparing food. We just kind of want to let them be as isolated as possible while they're having symptoms. Hand hygiene should be performed. If you're like in a hospital environment, you're wearing gloves, you want to put these, do hand hygiene before and after taking gloves on and off. And it's not wearing gloves, it's the substitute. You can't just pull the glove on and not clean your hand. And now whether you use soap and water or an alcohol-based hand rub, you want to scrub for about 20 seconds. You're making sure you get between the fingers, under and around the nails, the backs of the hands, and the thumbs. And if you're in a hospital environment or a petting zoo, you need to have something, hand sanitizer or soap and water available so that people are able to follow those recommendations. Then I'm going to try to squeeze through the last pretty quickly because I'm running out of time, but we have 4 steps to food safety. So we want to make sure, again, that we're cleaning our hands before and after handling raw meats. And we want to make sure that our surface is clean and disinfected. If we're working with raw meat, we want to replace the items that we use, like cutting to cut it, or any of the food prep items. We want to replace that or clean it before we use it on other foods. And we want to wear gloves if our hands have any cuts or abrasions. We want to keep the raw foods separate from the other foods. So it should be kept in some sort of container that will prevent any of that meat juice from leaking onto our other foods. Ideally, we can have a dedicated cutting board for meats. And again, we're going to clean or replace plates and utensils to avoid cross-contamination. This chart from foodsafety.gov does go through the different types of food and the internal temperature that's needed to kill pathogens. We want to chill foods that are not going to be eaten right away. We want them to be in the fridge within 2 hours. If it's warm out, if it's over 90 degrees, you don't want these foods out of the fridge for more than 1 hour. There's a danger zone between 40 degrees and 140 degrees. So we don't want our food to really get in that temperature. We want to eat our cold foods while they're still cold. For things that are cooked, we don't want them to cool off too much before we eat them. When using coolers, ideally, we can keep a thermometer in there to keep track of the food, make sure that it's staying the appropriate temperature. When we are grilling or smoking, when we marinate, we want to put that marinated meat in the fridge. If we're going to baste, when we make the marinade, we're going to put some aside to use for the basting process. We don't want to use that marinade that's been in contact with the raw meat. And then we have lots of public health measures in place to help protect the public that will help guide testing, how often it's done. We'll regulate the use of biosolids. They inspect farms and processing plants. They keep our drinking water safe. In facilities, I mentioned this earlier, so just very quickly, any patients with GI illnesses will be in contact isolation, and at minimum, staff will need to wear gum and gloves before they go into the room for any reason. For people that work with food, there are some different regulations, so they should not be handling any food if they have diarrhea and vomiting and shouldn't be back at work for at least 24 hours. Management has to be notified if any employee has these symptoms, and they must notify the health department if the employees have salmonella, norovirus, Hep A, Shigella, or S-Tech. And then, sometimes depending on the diagnosis, the employee may require clearance by public health before they can return to work. I mentioned earlier those stool cultures will have to be reported to the local health department within 1 day. The lab will send information to the health department regarding the specimen, the results, and they'll send a sample, but the facility will have someone that will provide additional information. And it's important that we get these folks involved early so they can investigate and identify any outbreaks. This is just a screenshot of the form that's used in Kentucky, and you can see that the person will be filling out demographic information, what the patient has, were they hospitalized, do they attend school or daycare, or do they work with foods, along with some other information, and that really is going to help them during their investigation. So take-home points are really that pathogens are responsible for foodborne illnesses can be found in animals, food, or the environment, and we need to be aware of those etiology and risks, know when and how to perform hand hygiene and the steps to reduce contamination of food and drink, and recognize symptoms that require evaluation by a healthcare professional. And that is the end of my slides. I am happy to answer any questions if anyone has any. Okay, I don't see anything. Please feel free to reach out to me, email me if you have any questions or if there's something I didn't cover that you would like me to cover. Thank you so much for joining us today.
Thanks, Dr. Forton. Appreciate it.